Dear colleagues, I got this enormous task to talk about histopathologic breast imaging correlation for a breast imager. This is such an important subject. Promise to me that you are going to be open-minded because we radiologists created a revolution, and unfortunately the histopathologic terminology and technique lag behind about 100 years. Why do we have a problem in understanding the histopathology report? Well, the answer is very simple. The pathologists are talking about cellular details. When was it last time you saw cells on the mammogram, on the MR, on ultrasound? Never. So, there is an immediate communication problem. And you went to school and you learned that this is God Almighty. I don't think so, and I'm going to prove it to you. So what's the solution? How are we going to understand each other? We have a very interesting solution to that. The large format, so-called 3D or 6-section subgross histopathology. Why? Because that shows structure. Yes, we radiologists see structure. Here is a subsegmental duct. Its reflection on the mammogram is going to be a linear density, and another linear density separated by adipose tissue. And this one, which one day produced the milk, is going to show up as a nodular density. We increase the resolution of the mammogram, and that's called microfocus magnification. Even if we decrease the magnification factor of histopathology by providing the lowest power histopathologic image, it still shows cells and doesn't show the structure. Therefore, we use 3D or subgross 6-section histopathology, which is 1500 micron thick. The conventional histopathology shows 4 micron thickness, while the breast after compression is 30,000 micron. So now we see the whole breast and 1500 micron, 1.5 millimeter. And because the duct measures in resting phase 0.1 millimeter, it really doesn't matter whether it bends or not, you still see it in the 1500 micron as a tube. And we see the milk factory, the terminal ductal lobular unit, as a nodular density. Neither the 3D pathology nor the mammogram show cells. That's why these two are friends. And when we understand the structure, understanding the cells, that's just one step away. Let me show you an example. You find these long calcifications, obviously malignant type for any well-trained radiologist, and you guess that their location is in ducts. So you go to the tumor board, and what you experience is this. They are showing you cells. And then the pathologist is going to talk about mitosis, solid cell proliferation of cancer cells, micropapillary cell proliferation, necrosis. Do we understand each other? Of course not. What's missing? Obviously there is a gap here, and that has to be filled. And that's exactly what the 3D histopathology technique is going to provide. That is, same case here. I go to the tumor board, and I'm telling the pathologist, I think that these calcifications are localized in a duct, in a tube. Would you mind showing that duct to me? This is 3D pathology. Dear colleagues, this is a duct within which there are the calcifications. This one and that one corresponds to any of my calcifications. Great. I got a confirmation that my educated guess was correct. The location is within the ducts. Inside the basement membrane, there is this thickening. What is that? Now comes the 2D histology handy. We cut through between the calcifications. And now I can understand this thickening is nothing else but a solid cell proliferation of cancer cells over each other. And then here is the necrosis. But where is my calcification? Let's cut through your calcification. And here it is. Here is the calcification within the central necrosis. And the thick layer here is the solid cell proliferation of cancer cells. Next time, I'm going to think like this. I hope I made my point. The conclusion is, We firmly believe that competence in breast image interpretation can be best achieved by correlating the large format, thick section histopathology with a mammogram, with a MR, and with any other imaging method. John Azzopardi was the chief of pathology at the Hammersmith Hospital in London. He wrote something very interesting we have to think about. All pathologists accept that before they study and report the pathology of the kidney or a liver or any other organ, they have to understand and they have to study the normal structure of the kidney, the liver, and other organs. Unfortunately, some don't do this. They delve into pathology of the breast without knowing the normal structure and its variations. And this is so true, dear colleagues, so true. So, of course, I borrowed his sentence. Many radiologists who undergo fellowship training immediately want to know what a cancer looks like. In most of this lecture, I am going to teach you the normal structure and then its distension and distortion by benign or malignant processes. A key is 3D histopathology. This is the milk factory, the lobule, and the terminal duct, and the subsegmental duct, and the major lactiferous ducts. Look at the comparison with plants. Both of them operate with fluid transportation. The only difference is the direction of the fluid transportation. We wrote a book about it, Understanding the Breast in Health and Disease. First in health, and then in disease. As you see, the viewer, the eye, nose, mouth, through the stereoscopic glasses built into the book. She can see, you could see, a pair of stereoscopic images. And then the effect is 3D. It's an entirely new world. But this is exactly the basic for understanding mammograms, MR, ultrasound, any imaging method. Specimen was floating in wintergreen oil poured in the petri dish. And the size is about 10 centimeter by 8 centimeter. Not too many people tolerate the very aromatic smell of wintergreen oil, so nowadays we plastinated them. I have about 200 specimens. Tom Stavros visited me with his lovely wife, and look at his hand. I don't need to describe the size of these specimens. And here is the cabinet with all these plastinated 3D specimens. We are absolutely convinced that progress in histologic mammography correlation can only be made by examining the histologic specimen in greater length, width, but also for teaching purposes, in depth. The date today is 2022, and we wrote this more than 20 years ago. When colleagues came to me from different countries for training and learning mammography, breast imaging, ultrasound, MR, I didn't show them mammogram for days. They had to study 3D pathology, the normal first, and then how the pathology distends and distorts the normal structure. They looked at the specimen against hotspot and in the microscope. When they understood the 4 basic building blocks and their relative proportion in different mammographic parenchymal patterns, then we went and studied the reflection of this on the mammogram, on MR, on ultrasound. We have a huge problem, dear colleagues. You buy into everything the pathologist is saying. You find a non-palpable stellate lesion, and you buy the invasive ductal carcinoma term. This is a professional mistake. This originates from the lobule, from the luminal cells. Likewise, the microlobulated, ill-defined circular lesion has nothing to do with the ducts. Yes, it's invasive carcinoma, but it originates from the acini, from the luminal cells. It's acinar adenocarcinoma of the breast. The histopathology technique is about 200 years old. Can you imagine? that you see the whole mammogram. And they give you a little piece here and a little piece from here and a little piece from there. And, shame enough, they throw away the rest. You don't even have a chance to double check. And then they come up with the second generation prognostic factors, the ER, the PR, the HER2, and so on. And nowadays, they threaten you that this is the future, molecular biomarkers. Not many of you understand this, but let me make one thing clear. None of these can compensate for the limitations of small chopped onion type histopathology technique. I hope that you're familiar with our new publications. Already 4 articles came out within this year, and an oncologist wrote an editorial. Please read what the oncologist wrote. First of all, current histopathologic terminology and practice technique seem to be misleading in many ways. There is a need to radically change the TNM classification system. Reporting the detection mode, that is screen detected status, is a very good prognostic factor. And the imaging biomarkers, which means what does the mammogram look like? An oncologist writes this because that, the third generation prognostic factor, the imaging biomarker, is going to tell you the biological behavior and is going to influence the management. We have to introduce and accept new terminology and a classification and using large format histopathology technique. Are we facing a revolution? We should. So let's look at how the breast is built up. More than 120 years ago, Sir Astley Paston Cooper, a British surgeon, injected colored wax into the different openings of the nipple. And you know that there are about 15 or so openings on the surface of the nipple. He got this picture, the lobes. You see, they are different sizes. They don't communicate with each other, but they interdigitate. Using modern technique, contrast medium, I can show you the same thing. The trunk of the tree, the main lactiferous duct. And we are going to realize that there are indeed branches, but that's not too many. What the tree has many of is the thousands of leaves the female breast needs, the milk-producing terminal ductal lobular units. That's why the comparison is so simple. And learning is fun. The trunk of the tree, the main lactiferous ducts, the branches, and the leaves, as well as the terminal ductal lobule units. Dear colleagues, this is a single lobe. Easy to understand. And now we are going to go to the small details. If this is a terminal duct, then these are the acini. Unfortunately, our resolution ability is not good enough to see the details, but there are about 50 or 60 acini per lobule. And it's in here. This is very important, partly because the milk is produced there, and partly because about 75% of the breast cancers originate from the acini. If it's a cluster calcification, it's cancer in situ, but not ductal. If it's an invasive carcinoma, then it's not ductal carcinoma. A huge difference compared to the current misleading, anatomically incorrect terminology. Isn't that beautiful? You see all 4 basic building blocks in front of you. This tube is the milk duct. And this about 1.5 millimeter little lobule has those many acini. And we are radiologists. We are putting an X-ray tube above it. And that's what we get. And this is what I call the black and white histology. And this is what I call the color mammogram. Just think about it a little bit. So you see, we have to understand and account for every single nodular or linear density. This is going to be the terminal ductal lobular unit, This is going to be the duct. And of course, this, what is called glandular tissue, needs supporting tissue, and the radiolucent makes the radiologist happy. The radiopaque, the fibrous tissue, doesn't make the radiologist happy. 4 basic building blocks. You got 4 bricks and build a house. So this is what I mean, special training in mammographic histology correlation, using the techniques of large format thin and large format thick section histology, makes the radiologist understand and also account for every detail of the normal mammogram, well before we are talking about carcinoma or hyperplastic breast changes. Knowledge is power. After this introduction, I hope you want to see a mammogram. Let me see a mammogram, because I know what this is. That's going to be the duct, and I know what these small nodular densities correspond to. That's the normal terminal ductal lobular unit. The whole picture gives harmony. That's what normal mammogram looks like. And out of 1,000 screened, 960 are normal mammograms with all the variations we are going to talk. I look at this mammogram, and then the first impression is that the fibrogranular tissue is localized in the upper half, while it already retired from the lower half. And now I can account for that linear density, that's a duct, and those nodular densities, that's the terminal ductal lobular units. And I can go on and just enjoy my newly found knowledge. And I want to read a mammogram instead of saying, oh no, not again. Beautiful, isn't it? I'm not going to explain to you. You understand. The acini, the terminal duct, the terminal ductal lobular unit. And once again, transportation of fluid goes in this direction in the plants, and transportation of fluid goes in this direction in the breast. That's why the similarity. You could ask the question how to read an MR. Well, if you have the thin MIP images, then of course the story is exactly the same. Here are the terminal ductal lobular units, here are the ducts. Here is a duct, and here are the terminal ductal lobular units. The duct is here, and the corresponding TDLUs are here. One of our problems is that the anatomic structure of the breast shows great diversity. Look at this large section. Under this square centimeter versus under this square centimeter. Entirely different tissues. And that's why our peers have to understand and respect the poor radiologist. That's why it's so difficult to read a mammogram. After having learned the 4 basic building blocks, we arrive at a very strange, a very unusual phenomenon, namely, unlike other organs, the breasts may have very different appearance on the mammogram. 5 different women may have entirely different mammographic parenchymal patterns, and the same woman with 10-year difference may look different. The basic structural elements can be found in each of these, but their relative proportions vary widely. And that makes the reading very difficult, and it's going to also influence our ability of finding pathologic lesions. With all due respect to white reds, I don't think you need to go to medical school to say 25%, 50%, 75% or so. However, you definitely have to go to medical school and learn mammographic 3D histopathology correlation to understand that pattern we call pattern 1, the most frequently occurring mammographic parenchymal pattern, changes. And during the decades, it's going to change because these small TDLUs are going to realize that she is not going to be pregnant, so it becomes a pattern 2 or pattern 3. But if she decides to become pregnant or takes HRT, then wintertime turns to springtime again. This accounts for about 12% of the population, and this never changes. 5 to 8% never changes. This is a joker. I don't know whether there is a rich glandular tissue under it, or desert wintertime. Pattern 1 has about the same amount of nodular, linear densities, fibrosis, and adipose tissue. And the TDLU does the job. Proliferate, involute, hope and disappointment, hope and disappointment. After a while, as I mentioned to you, they realize that she is not going to become pregnant, so the fingers retire. Wintertime is on the way. They used to be very diligent and produce the milk that was running into this terminal duct and the subsegmental duct, making the baby very happy. But now, wintertime is coming. Fewer and fewer, smaller and smaller TDLUs and skinny ducts. Just like in winter, on the tree, the ducts, the branches of the tree, don't disappear. They become skinny. What disappears is most of the leaves or the TDLUs. And then we arrive at the dream of the mammographer entitled fatty replaced pattern 2. This is what a galactogram looks like. Just like in winter on the tree, not every leaf or bud is going to disappear. And that explains why women with fatty replaced breast can get a breast cancer. Much lower risk, of course. But because 80% of the women at age 70 have fatty replaced breast, quantitatively, the largest number of breast cancers are in fatty replaced breast. This is what we are talking about. And so we arrive at pattern 2, where the adipose tissue dominates the picture. And here is the example. Some of the buds survive, and they may result in developing a fibrocystic change or any other hyperplastic breast change. Pattern 3, when you see these retroareolar distended ducts, and what distended duct? Fluid, or cancer, or fluid caused by cancer. Now these are usually inspissated material, very thick viscous fluid in the retroareolar ducts. Ultrasound is a godsend, highly proteinaceous, too viscous to come out through the surface of the nipple. Pattern 4. It's a simple adenosis pattern. What does adenosis mean? While a normal TDLU has 50 fingers, 60 fingers, this happens to have 120 or even more. So it becomes bigger, hypertrophy, and more means hyperplasia. What is simple adenosis? Is one of the hyperplastic breast changes, which is characterized by hypertrophy and hyperplasia of the terminal ductal lobular unit. And that's why you see these big snowflake-like radiopaque densities. Comparison with nature. 3D pathology. When you look at this, I hope you have this in mind. There is physiologic adenosis, and that's called pregnancy and lactation. This is an acinus, and this is called milk. Of course, it's not 1.5 millimeter, but much bigger. And the ducts are distended, contorted. You look at it, bilateral symmetrical picture, you know exactly that this is lactating breast. You see the difference before and during lactation. But then it goes back to normal after lactation. It's pattern 2. Pattern 1, pattern 2, physiologic change. Pattern 4 never changes. About 12% of the population has this. No change. Unfortunately, there are many more cells in these elongated larger number of acini. Cancer is the malignant proliferation of epithelial cells. If there are more epithelial cells, higher risk of getting a breast cancer. Indeed, also in Chinese women, our statisticians published that pattern 4 is not only a high risk of developing breast cancer, but also more poorly differentiated cancers develop in this pattern. Watch out with that one. Pattern 5, massive fibrosis, convex contoured, homogeneous, ground glass-like. It can hide everything, the normal structures, or, as in this case, the patient had a 29 and a 12 millimeter carcinoma. Well palpable, but not visible on the mammogram. More histologic mammography correlation and more clarification of incorrect terminology. Cooper's ligament. Unfortunately, this is not a ligament. My Achilles tendon is a ligament. This one is not. It contains 3 out of the 4 basic building blocks. The concave contoured fibrosis, what we see here, and then the TDLUs and the ducts. So, if there are ducts and TDLUs, then cancer can develop within the Cooper's ligament. It's not a ligament. It's a normal fibrogranular tissue. Here's a cyst developing. Here's a fibroadenoma developing. Adenosis developing. Atrophic TDLUs, ducts, and fibrosis. Fibrocystic change, apochromatoplasia, and unfortunately breast cancer. This breast cancer originates from the major lactiferous duct. We call it neoductgenesis. And it goes all the way under the skin. So today's forced-on breast conserving surgery is going to leave this behind. And because this is a stem cell carcinoma, radiation is not going to kill it. I would recommend for you to read at least the first 150 pages of our book, which only deals with the normal. And now you understand why I'm pushing this so much. Because that's exactly what you don't learn in school. And that explains why people have 15-18% callback rate. We have 2.3% callback rate, and we already decrease mortality by 60%. It can be done.